Hi, welcome everyone. Thank you for joining. Just give us 1 minute while we wait for everyone to join, and we will start after that. Okay, I think let's get started. So thank you all so much for joining. Really excited to be with you today. My name is Will Brown. I'm a senior director at Vista Health, who's been working with APACMed on this white paper that we are launching today. The paper is entitled Advancing Patient Access to NGS for Cancer in APAC, Key Considerations and a Value Assessment Framework. This paper is made available on the APACMed website and will be publicized also further through LinkedIn and websites after the webinar. But really excited to host you all today and to take you through some of the key findings from the paper and also have some good stimulating discussions on the topic of NGS access. So I've already introduced myself and I also have alongside me Anirudh from APACMed. Maybe I'll just invite you to introduce yourself briefly, Anirudh.
Hey, thanks, Will, and good evening, everyone. Great to see the numbers here today. I think there's a lot of interest in this topic. So my name is Anirudh, and I lead the market access and IVD committees at APACMed. And of course, I will be talking a little bit more about who we are, what we do, and why did we decide to work on this topic later on.
Thank you, Anirudh. So the agenda for today is quite a packed one. So we will push through each part. We're going to start off with an introduction from Anirudh around APACMed and the project itself. I will then take you through an overview of the key findings and considerations from the white paper. Before we go into 2 panel sessions, we're going to hear about implementation and the value of NGS in England and Sweden, 2 of our reference countries and systems. And then we'll be having a APAC panel discussion on those two presentations as well. So thinking about how we can take some of the learnings from these reference cases and apply them to the Asia Pacific region. So with that, let's start with the first section. So I'll hand it back over to Anirudh to talk through an intro to APACMed and also the project and initiative here.
Sure. No, thanks, Will, again. And again, a very warm welcome to all of you to today's webinar and the paper launch that we are here for. So I understand we have quite a few APACMed members joining us, but we also have quite a few professionals who have joined us who are not familiar with APACMed. So I'll just give you a quick background of who we are. So we are the only regional trade association or representative body for manufacturers and suppliers within the medical technology sector across the Asia Pacific region. Our core mission is, of course, to enhance patient care standards through collaboration among stakeholders. And we're actually celebrating our 10th year this year. So we were established actually a decade ago in 2014 with C-suite executives from large medtech companies actually deciding to bring together the community and form a regional trade association, which represents the voice of the industry in the Asia Pacific region. So we are committed to promoting innovation and influence policy shaping, which ultimately, of course, give better access to these technologies to patients across the region. So that's a bit about who we are. We're based in Singapore and have offices in India and China, and we are membership based. So we have over 350 members, and out of which about 60 of them are large corporate companies, the medtech companies. So that's who we are. If we talk about the project, yeah, maybe we can move to the next slide. Um, so why did we choose this topic? So, like I mentioned, we our ecosystem comprises of medtech companies, IVD companies as well. So, so one of the groups within the market access committee was the IVD group, and one of the topics that we decided to cover was NGS, because I guess in the last decade. I think we've seen a remarkable surge in genomic research, and particularly its application in the healthcare space. There have been significant strides in the APAC region to enhance its accessibility, but I guess there is still a lot to be desired, and that's where I think the members decided that we need to come together and kind of put together a landscape study to see what are the current challenges, what is the current potential that this has, particularly in cancer care, where we feel there is a huge potential for NGS. So, I mean, in view of this and to address the issues that I just spoke about, we decided to form a core team, and along with Vista Health, who has helped develop this paper, which we are going to be launching, today. We wanted to kind of present an overview of the current status of NGS-based cancer care in APAC. Also outline what are the necessary steps to improve that access. And this also includes the development of a unique value assessment framework for NGS, which is tailored to the regional context. So that's kind of another key element that we would be sharing with you during the launch of the paper. Before I hand the floor back to Will, I think I just want to take this opportunity to express my gratitude to the core team. So my colleague Benish was leading this along with all the member companies who are a part of the core team and Vista Health. I think they've done a fantastic job. And I think this actually highlights the collaborative effort which is needed to drive this change in our industry. So thank you all once again, and I'll pass it back to Will, who will then kind of share the next steps and move on to the panel discussion. So thank you all once again for joining today.
Thank you so much, Anirudh. Great. So what I'll do first of all is just introduce our speakers and panelists for today. So we have with us the two speakers from NHS England and Genomic Medicine Sweden. So we have Professor Sandy Deans, who's the Deputy Director for Genomics at NHS England, and Professor Richard Rosenqvist Brandell, who is a Director at the Genomic Medicine Sweden organization. So a pleasure to have you both with us today. And then for the panel discussion, we will have Tiffany Bortwood, who's the Managing Director at Australian Genomics, Professor Choi Yoon La, who's a Professor at Samsung Medical Center, and Crystal Barter, who is the founder of Humanized Health, a key patient advocacy group in Australia. So thank you all for taking the time to be with us today, and we look forward to hearing from all of you a little bit later on. Okay, so with that, I'll move on to talk through a brief overview of some of the insights and considerations from the white paper, starting off by looking at the landscape. If we think about the sort of current state of cancer and cancer care globally, obviously we will see differences in incidence and prevalence, as well as outcomes across the globe. One of the I think stark findings that came out of sort of the landscaping work of the paper is if you look at the ratio of deaths to cancer incidence, there's a significant skew. Right. In APAC, we see that this is more than half of incident cases end in death versus 0.44 in Europe or 0.25 in the US. And this is a stark reminder of the work that is needed across the board for cancer across the patient journey in the region. We also see alarming growth figures expected in the region. So you'll see 55, 67% there in terms of growth for incidence and mortality, which is going to make this disparity even greater if no change is made. Now, where NGS, next generation sequencing, comes into the picture is really thinking about how we can address this situation. There are many tools that are needed to tackle cancer and the burden that it places on countries and on health systems. As Anna had mentioned at the beginning, there's been a huge surge over the past 10 or so years in the sort of precision medicine space, which is driven by NGS. And NGS has been shown across the world to improve clinical outcomes, reduce the total cost of care, and improve quality of life for patients. So it's clear that this is going to be a really important tool to help us tackle the rising burden of cancer in the APAC region. However, there are barriers to patients getting access to NGS in the region. In the paper, we identified and defined these 7 barriers, split across policy, clinical, and reimbursement and HTA domains. We see that there is a lack of full NGS inclusion into national strategies across the board. We see a lack of coherence across the different types of policies in countries. We also see a lack of overall investment into the testing and data infrastructure that is needed to provide access to this technology. From a clinical perspective, there is still a lack of awareness and education amongst healthcare professionals, and also a lack of localized clinical guidelines for NGS. From a reimbursement and HTA perspective, we often see siloed funding across the APAC markets. And we also recognize that conventional value assessment frameworks do not really appreciate the full potential of NGS. In the paper, we explored across all of the markets that we looked at, which represent a range of different system maturities and also different burdens of cancer. We recognize that it's a very heterogeneous landscape. There is a wide range of sort of strength or severity of these barriers across the different markets in the region. And this, of course, means that any of the considerations, any of the recommendations from the paper need to be looked at with that local lens. We also recognize that this is a quickly shifting, quickly changing landscape. Just in the last 6 months, we've seen positive changes in Taiwan, where the reimbursement for NGS has been provided for the first time. And also in Korea, on a more negative note, the repeal of some of the reimbursement that was previously made available there. So it's a changing and a difficult landscape to sort of characterize for one region. And so in the paper, you will also see that sort of tailored view by the different archetypes of markets across the region. If we think about these barriers and start to think about how to address them, the way in which we tackled this was to think about these from a sort of funnel approach. If we look at the policy and the clinical barriers, and also the first within the reimbursement related, which is the siloed and insufficient funding. These are almost in a way sort of upstream or prerequisites that need to be addressed before the last barrier there, the value assessment, can then be actually addressed. So we sort of see, and through the paper, we talk to this funnel approach, where these barriers need to be tackled sequentially in order to reach the end goal of long-term sustainable funding and access. So that moves us nicely on to some of the key considerations to increase access to NGS for cancer. Against each of the categories of barriers, we have proposed considerations to improve access across the region. I won't read through each of these, and these are detailed clearly in the paper, but just to touch on a few highlights. At the foundational level, at policy level, inclusion of NGS in national strategies sets the tone for how this will be looked at by all other stakeholders, and ensuring that linkage between regulatory, reimbursement, and clinical implementation at a policy level is also critical. From a clinical perspective, really needing to further promote the understanding of the impact of genomic information on patient outcomes, and also to have those national localized clinical guidelines is also critical. From a reimbursement and HTA perspective, in the sort of early stages of a systems development towards NGS, looking at alternative funding models beyond the sort of usual ones may be important. And then to gradually expand government-led funding to make sure that the access is more equitable. And one of the key ones, which we'll talk a little bit more about, is the fit-for-purpose value assessment framework, which is one of the key considerations coming from the paper. We also mapped out to think about who needs to take what role in order to make this happen. And so you will see that from a sort of policymaker, decision maker perspective, there will need to be involvement across all of these considerations. But for each of them, there will be different stakeholders who need to either lead or support the different initiatives. And this, I think, also represents the need to have a sort of holistic and connected approach across all stakeholders. Okay, so the last part for my sort of highlights from the paper is around the value of NGS and how we can look at a more fit-for-purpose value assessment framework. So we have the sort of usual or traditional methods of value assessment, which typically focus on cost savings, health system efficiencies, and clinical utility. But NGS is a multi-indication, multi-recommendation technology that doesn't only offer these benefits. So to see the sort of full value, the bigger picture value of NGS, we also need to look into additional elements of value. And in the paper, we detail out, across the economic, clinical, individual, and societal values, the different ways in which we would recommend stakeholders to consider the value. So from the traditional health system efficiencies and cost savings through to broader impact on the economy, the clinical utility, diagnostic accuracy and reliability, and also the often forgotten elements of patient and caregiver empowerment and the broader societal implications. As I said, detailed out much more in the paper, which we would strongly invite you to read after this. And we would love to engage with you further on these topics. But I believe I'm over time, so we'll move on to the next section. And in light of the paper, and within the paper, actually, we feature several case studies, including NHS England, as examples for the APAC region countries to look towards. And so we've invited Professor Sandy Deans to introduce to us how this has been done in the NHS in England. So I'll hand over to Sandy now.
Thank you, Will, very much indeed. And thank you, everyone, for the opportunity to share the experience of setting up the Genomic Medicine Service across England. So if you just move into my slide deck, please. So the Genomics Medicine Service across NHS England was initiated in 2018. And really the idea was to bring together some sort of formal structure and oversight and funding for genomic testing. And in 2022, we launched the genomics strategy. And really we had 4 pillars and key themes across the service that we wanted to prioritise. The first one was very much about embedding genomics across the NHS. So this wasn't just about having silo testing in particular laboratories where specialty or interest lay. It was about making sure it was in the normal care pathway of patients within the NHS. We also wanted to make sure this was equitable across the country. So there wasn't just pockets of good practice. It was about any patient being situated and seen in any hospital or care setting would receive the same opportunity for genomic medicine testing. We also wanted to make sure that we had the infrastructure in place. We know that genomics, particularly next generation sequencing, generates a vast amount of data and digital resources, and really we had to handle that in some way. And the NHS was not known for having great informatic technology and infrastructure. Also, what was really important is we all know the field of genomics is moving in such a rapid pace that we needed to make sure that we had that link between the great research and development that was happening across the country, and we could then fast track that and the developments into mainstream clinical care. So it was about having that translational gap filled between research and mainstream care. And this type of strategy was underpinned by these multiple documents here that had been previously produced in the country. So next slide, please. So how we went about it in 2018, we set up a network for the Genomic Medicine Service. So this comprised of 7 genomic laboratory hubs, which worked in a hub and spoke model across a defined geography. These linked into the 17 clinical genomic services, so we were working with clinical genetics at the same time, plus the 7 genomic medicine alliances. And this was about pathway mapping, working with our clinical teams, and that was incredibly pertinent when it came to embedding into cancer services. So it wasn't about disrupting cancer pathways that were currently in place, it was about integrating genomic testing into normal cancer pathways. One of the key areas that we have launched in the last 2 years is establishing cellular pathology genomic centres, whereby they actually are dedicated to handling tissue, fresh tissue and FFPE-based tissue, to be able to feed the next generation sequencing pathways within our NHS system. And we also commissioned Genomics England to deliver the whole genome sequencing service, which includes many cancer indications. So next slide, please. The main drivers of achieving this is we created a national genomics test directory. So for the first time, we had all of our laboratories across the whole system complying and delivering the same services. So the genomic test directory determines who should be tested, when they should be tested in their cancer pathway, what should be tested and how it should be tested. And we have made over 350 updates to the test directory since 2019. And really that reflects the responsive nature that genomics has to have to be able to incorporate either the new biomarker testing, and we have many of those coming through linked to treatment and personalised medicine, but also the new technologies coming through. And next generation sequencing is one of those, whereby we are now replacing many of the single gene tests to get much, much more genomic information for our cancer patients from the same test. So next slide, please. So I just want to talk a little bit about how we deliver our cancer genomics. And I think the take-home message here is the change that has evolved. So we have three elements of cancer genomics. We have our germline testing, whereby it's very much based on next generation sequencing to deliver those germline results, including DPYD, for example, which is a pharmacogenomic test linked to drug treatment. So it's about getting more information from that test. We've also got our integration of the large panels, which is also along with other testing methods here you can see, and our whole genome sequencing, which is very much based on next generation sequencing to get that extra information. And then finally, my next slide, I just wanted to summarize about how we actually managed to drive the change in the NHS through NGS implementation. So I think the real key one, the highlight, is about centralised funding. So for the first time, genomic medicine was actually funded properly, rather than it being siloed funding and also through potentially pharmaceutical companies funding. I'm not sure if you can see the next slide. I wonder if you can just move it on. Thank you. Part of that as well is about making sure that we've got equity, so that what we are funding and commissioning is delivered, and we can do that through what we call patient level contract monitoring. So we have a feedback and data audit that is performed monthly to ensure that we are meeting the demand across the service in an equitable fashion. We also are seeing increased diagnosis coming through the use of whole genome sequencing. So again, it's about that patient and clinical engagement to demonstrate the value of whole genome sequencing. We also see the reduction in the use of standard chemotherapy regimes, so reducing harm, reducing adverse drug reactions through the use of personalised medicine that is targeted to particular biomarkers that we are detecting through our NGS service. We also managed to increase clinical decision-making options, so we have more information for the clinicians to be able to drive treatment, personalised treatments, and also use that extra information to access clinical trials. So I think in summary, we can say that the NHS Genomic Medicine Service really has started to embed, and we can now see the change that's been driven by new technologies such as NGS. We've got cancer genomics now embedded into mainstream clinical care, and that we can generate the evidence through clinical utility and doing health economics to demonstrate cost effectiveness to put the test on the test directory, so we can actually demonstrate the benefits of NGS testing. And then also we can work with research and our other key stakeholders to bring rapid adoption, as I say, to transform the NHS care. So thank you very much.
Thank you so much, Sandy. Great to hear how this has been done in the UK. What I'd like to do now is we'll bring Crystal, Yunla, and Tiffany. If we can also pin the videos, please, along with Sandy and Richard, to discuss a little bit about the case study that we've heard from NHS England, and think about what lessons can be learned for the APAC region. So maybe just to kick things off, I think one of the defining features of the presentation by Sandy was around the sort of top-down push from a policy perspective. And also, you know, that leading to the formation of the genomics service. So maybe could I invite Tiffany to start us off, just your reflections on the sort of benefits of that approach. And obviously that's not going to be the case in every country in the APAC region, but would like to hear your thoughts about how that can be taken as a learning.
I'm happy to speak to that, Will. Thank you. And Sandy, thank you so much for the presentation. That was just, it's an excellent exemplar to get us all fired up about embedding genomics in cancer care and control. I think too, I mean, certainly the formation of the 100,000 Genomes Project and Genomics England was very much this sort of policy and strategy driven exercise. But I was really struck in Sandy's presentation about the description of this strategically developing this entire ecosystem in order to coordinate and deliver genomic medicine and really embed that into standard of care and healthcare. And the fragmented approach that many of us are facing within our jurisdictions across APAC make that really sort of strategic ecosystem development challenging. So that would be my point one. My second point would be, I was very interested in the 2022 NHS genomic medicine strategy that Sue Hill always says to me, have you read it? I'm like, I know this thing off by heart. What are you talking about? But, you know, on your slide, it said predicting, preventing, and diagnosing, which I thought was a really interesting twist from many of the nations across APAC. It's basically, you know, we've got a sick person, we'll achieve a diagnosis if we can, we'll throw whatever works at them, you know, for most other patients and see what happens. There's a real challenge in embracing this preventative healthcare, this model of stemming the tide early, so then, you know, for the benefits of patients and benefits of the system more broadly. So they were the two sort of, I mean, I was impressed with the presentation throughout, but they were the two key takeaways that I thought were very interesting.
Great, thank you, Tiffany. Maybe Prof. Choi, could I invite your thoughts on the case of NHS England, and also thinking about the Korea perspective, as we know, there's been sort of the recent rollback of reimbursement there. What do you feel we can learn from the NHS England example that may help to further the access situation in Korea?
Thank you so much. The nice presentation and review of your system is really impressive. And first of all, the kind of a genomic national approach is really good system. So first, thank you for giving me the chance to share my thoughts on this important issue, especially for your interest in issues in Asia Pacific region. I'm not familiar with all the details in Asia Pacific area, and Korea has its own unique situation. So I will focus on the current situation in Korea. It could be some kind of, the thinking starting point, especially in Asia Pacific area. Korea has a government-covered healthcare system, so where all medical care is provided by the government. I think that's similar to Taiwan. In 2017, already more than 5 years ago, the Korean government began covering 50% of the cost for panel-based NGS for several types of advanced stage cancers and genomic disease. It's really good for medical person and patients. Now more than 40 institutions in South Korea has NGS equipment, and most of them can test large panels. However, due to the healthcare financing issues and the expert advice that the actual clinical utility of NGS is not proven yet. So the co-payment rate for NGS testing was increased up to 80% for the cancers, except lung cancer, which has actually proven the clinical utility since the last year. So this means that actually the patient access to NGS has been reduced. The government says that it will review the reimbursement if more evidence of clinical utility is submitted. But the main issue is that actually the clinical utility totally depends on the number of drugs they can describe. So even though many drugs have been approved recently, it is not easy to have a useful number of drugs for most tumors, considering the domestic situation and medical cost. So experts have the different opinions on the rationality of this decision and situation. However, in the end, I think it's important to discuss who will pay for the necessary cost for the NGS. Yeah.
Thanks, Prof. Cho. Yeah, I think it's a really interesting point around, where in the lines of therapy or lines of treatment it's used, right? Often in a lot of countries, it's at a very advanced stage that it's reserved to be used. I think we've seen that the NHS England approach is very different to that and trying to sort of bring it earlier and earlier. Maybe, Crystal, from a patient perspective, how do you view this? I mean, of course, there's always going to be that push to have it used earlier, to know earlier. But there is then, the trade-off with how that is funded. But what's the patient view on how this access should be best provided?
So I can speak from my point of view, where everyone in my family on my maternal side has had cancer in their 30s and 40s. So I know what heartache and pain comes from a late stage diagnosis of cancer. There should not be a patient anywhere around the world where this technology is available that should not have their tumor tested when they're diagnosed with cancer. If there is an available treatment that is more personalized for them, that reduces harm, gives them best quality of life, we should not put them through 2-3 lines of treatment, archaic chemo that will, ultimately it nearly killed my nan and other people. They were so sick from it. We shouldn't have to do that when we have the science and technology available, and it ultimately ends up more cost effective, right? Genomics England has given us the blueprint for what best practice can look like. They don't get everything right. No one will get everything right, but by God, they're giving it their best shot. And as a patient, as an advocate who's worked in the genomics landscape, we look at that and we hold that as a pillar, as something that we should all strive to do. There is no excuses anymore. Genomics has been around for a long time. My family had a single genetic test over 23 years ago, nearly 24 years ago, that told me I was BRCA positive. And the fact that we don't liberally give this available to patients, full knowing that the evidence, the data is there, we still make it so difficult and so challenging around the world for patients to access. It is a failure of healthcare at the end of the day. And collectively, if we all work and strive towards the change that we need, we just might get there, and patients might get access to the personalised genomic healthcare that they deserve.
Thank you so much, Crystal. Very, very inspirational words there. Maybe just a final comment from Sandy, perhaps just to reflect on what you've heard from Tiffany, from Yunla, and from Crystal. Any words of advice for APAC countries?
I think we've been there, and I think it's truly the top-down engagement and the funding. But what we find challenging, yes, the long-term plan in the NHS is about earlier detection and prevention. But what's really difficult is the genomics budget increases to be able to achieve that, but the realizations come from all the other budgets across the healthcare system. So it's very difficult to demonstrate that actually it is that NGS panel that has released all this money across the rest of the healthcare. So that's the challenge, and we haven't fixed that one yet. We're still working on it.
How far away is Andy?
Well, for things like liquid biopsies and ctDNA testing, then yes, we've just done a big health economics report on the pilot that we've done for non-small cell lung cancer, and we can evidence the amount of money that's released by getting that earlier detection, that people don't have to go for a biopsy, or they don't have to go for multiple clinical episodes before they get that diagnosis and get early access to the treatment. So there's very clever ways. It's about that, again, new technology and new clinical use cases that can actually demonstrate the evidence of the benefits.
Let alone the broader sort of economic benefit to governments beyond health, you know.
Absolutely. Yeah,
they
absolutely.
very, you know, rarely take consideration of in health technology assessment.
Great. Thank you all so much. Really interesting case and good discussion. So yeah, thank you all for that. What we'll do now is move to hear from a different system. So I'm going to invite Richard to speak from the Swedish perspective. So over to you, Richard.
So thank you very much, and thank you for inviting me. It's great to be able to share our experience, and this is probably the opposite to what we heard before. This is a top-down or a bottom-up approach compared to NHS England. And let me have the slides, please. So in Sweden, which is a country of a population of 10.5 million, we have do not have national health care. It is tax paid to a large extent, but it's regionalized into healthcare regions that are autonomous from the state. So how did we start? In Sweden, we have a national infrastructure for high throughput technologies, including next generation sequencing. And we discussed with them, shouldn't we join forces 10 years ago in order to move the technologies into healthcare? And they were very positive. So we initiated clinical genomics unit at the medical faculties throughout the country in order to stimulate the process of transferring whole genome sequencing and panel sequencing into healthcare. And in this process, we decided, let's now broaden up and scale up to the whole country. And then we started Genomic Medicine Sweden. I can take the next slide. So in order to do this in a regionalized healthcare system, we have built this research implementation framework. So we take advantage of the national infrastructure for life science, Science for Life laboratory, and then the clinical genomics platform test and adapt different technologies for healthcare. They do that at the medical faculties throughout the country. And then we sort of move it over to genomic medicine centers that are located at all medical university hospitals in Sweden. Of course, Sweden is a small country. We have only 7 university hospitals, but with these twinning units, we have been able to reach the whole country, cover the whole country with the genomic medicine services. So we can take the next slide. So this was really a bottom-up initiative. We have government funding to run genomic medicine in Sweden. We really think this is a strong benefit for the country in order that all regional healthcare centers, they provide the precision diagnostics and of course the treatment. We have one physical in-commons infrastructure, the National Genomics platform, which I will come back to. I just want to point out that we have a national steering board consisting not only of healthcare and academia, but also industry and patients are board members to steer genomic medicine in Sweden. So we can take the next slide. So the National Genomics Platform, all genomic medicine centers, the 7 genomic medicine centers are linked to the National Genomics Platform. And here we both share and store data. It is some still legal challenges, but now we can do it if we have informed consents and all agreements in place. We are also waiting for a European health data space, which will enable us to do more direct secondary use of healthcare data. But this is a very strong asset for us in order to be able to effectively share data over the country. So we take the next slide. Next slide, please. So we cover a broad range of areas, rare diseases, 3 cancer tracks, but also infectious diseases, pharmacogenomics, and complex diseases. And I will show you from our 3 different cancer tracks. So if you take the next slide. In hematology, we started with national panels, one for myeloid malignancies and one for lymphoid, and it was rapidly introduced 2020 into healthcare. It is reimbursed. All the tests that most of them that I'm discussing are reimbursed by the healthcare system in Sweden. So we do now these gene panels across the country, and it's used for diagnosing, prognosing, and also for deciding treatments like bone marrow transplantation. We are here also looking into shifting to whole genome sequencing and whole transcriptome sequencing, and this we have done now in parallel the last 2 years. And for pediatric cases, we are now shifting to whole genome plus whole transcriptome sequencing, and I'm sure that it will follow also for adult patients. We can take the next slide. For solid tumors, we have a broad cancer panel of 560 genes, which also includes complex markers. This is implemented at all 7 genomic medicine centers, and we have around 70,000 cancer cases per year. And for hematology, we do 7,000 gene panels per year, and for solid tumors, it's around 10,000. And we have also ongoing work with liquid biopsies that we mentioned, which I think will be very important in the future. We can take the next slide. For pediatric cancer, we have also, similar to other national initiatives, we offer whole genome RNA sequencing and methylation profiling. And this is now the first 118 cases, we could really see the clinical impact over. You can take the next, please. More than 90% clinical relevant genetic alterations. We do this at diagnosis, not at a later time point, so it's early diagnosis. You can take the next. And this led to the statement by the pediatric oncologist that this is now considered standard of care in Sweden. So since this year, it's reimbursed throughout the country for whole genome sequencing for solid and leukemic pediatric cases. You can take the next slide. So this is roughly what we are monitoring the sequencing every year. And you can see to the left that for rare diseases, we do around 13,000 whole genome, whole exomes in healthcare that is reimbursed, almost 18,000 gene panels, and it's roughly 90,000 NGS-based assays that we did last year in Swedish healthcare. You can see that we still are doing a lot of SARS-CoV sequencing, but we are sort of scaling up in many different areas. If you take the next slide, I just want to mention finally that it's very, very important in international collaboration. We learn a lot from each other. So it would be very, very nice to engage with many of your countries in the APAC region. So thank you very much for listening.
Thank you so much, Richard. If we can switch over or switch back, I guess, to the panel view now. Let's discuss what we've heard. Just give us 1 second for that. Great. All right. So yeah, thanks again for the sharing, Richard. Maybe to start us off, perhaps I can turn to you, Yunla. I think one thing I picked up on in the presentation was that this was a sort of very physician-led approach, that sort of bottom-up approach in Sweden. So just wanted to hear your thoughts on whether that might be something that also can help support the case in Korea as well.
Thank you for the wonderful presentation. First of all, I'm really curious about your country's situation about the clinical utility evaluation. So you mentioned even whole genome sequencing, and most of them are reimbursed from the government. So would you please let me know shortly?
Yes. So I mean, for instance, the hematology panels and the NGS panels, they are all reimbursed by healthcare. And for whole genome sequencing for rare diseases, We did 8,000 last year in Swedish healthcare. They are also reimbursed fully by the healthcare system. For pediatric cancer, yes, they are reimbursed, but then we are doing it for other like sarcomas and for adult acute leukemias and other hematological malignancies, and then it is still in research projects where we get funding from the government and from other sources in order to sort of move the barrier. So yeah, that's the case.
Okay, so I got it. So some of them are from the research-based funding.
The majority is reimbursed by healthcare, but we also have, of course, research projects ongoing.
Okay, thank you. Thank you so much. As I told you, basically the Asian Pacific market faces major challenges, including healthcare costs and the sharing knowledge and information. So there are a few things to consider at this point from my standpoint. First, as I told you already, when evaluating cost-benefit evaluation of NGS, I really would like to say that we should compare NGS to traditional testing method. What it means is that we often do not measure the cost benefit of a test we are used to, but we are very critical of a new test that are emerging like NGS. And the second, actually, this should we limit the usefulness of NGS to just prescribing drugs. The main advantage of NGS is that it can test many genes at once and identify a wide range of genetic conditions beyond the only drug targets. Since the classifying the type of tumor is just a starting point of diagnosis and treatment. So if NGS results can classify the tumor type more accurately and clearly, its clinical usefulness will increase, I think. In other words, the diagnostic usefulness should not be overlooked. I mean, we need to consider the diagnostic validity of NGS. A third, there should be a global effort to lower the cost of the test, and we should find ways to share the cost, maybe especially in Asia Pacific area. And lastly, the efforts should be made to share relevant knowledge and information more efficiently and effectively, especially in Asia Pacific areas. Yeah, thank you.
Just a short reply that we are doing cost-effective analysis, both microcosting of the type of NGS-based assay that we are introducing compared to standard of care, but also the health economy assessment. So we are sort of conducting this, and we have, for instance, one publication in rare diseases where we can show that it is health economy. We save money for society when introducing whole genome sequencing for rare diseases. So we see a decreased number of inpatient hospital visits and primary care visits and so on when we have used whole genome sequencing. So I fully agree with you, and I agree also with you regarding education.
Thank you.
Thank you both for that. I think, yeah, it's going to be really important for governments and industry to work together on this, for sure. It's going to be a key success factor. Maybe I could turn to Tiffany next, just to hear your perspectives on the Sweden case.
Absolutely, Richard, thank you. It does fill me with some hope coming from a nation that has very distinct sort of shared responsibility for healthcare delivery between the federal government and then jurisdictional governments. The fact that you could sort of unite these from this bottom-up approach and deliver a cohesive, sort of cancer care, genomic cancer care ecosystem is very encouraging. equally, you know, the commonality, Richard and Sandy, between your presentations around the critical nature of a cohesive data infrastructure as being, you know, a sort of foundational element for a genomic medicine strategy. I think that really struck me from both of them. But also, you know, just I think I'd really congratulate all your efforts in delivering this real boon for your citizens, you know, in a relatively small nation, but linked with European initiatives. One question I'd have potentially for both of you, if we have time, I'm conscious we're getting close. There's an increasing sense here, so the importance of not only digital infrastructure and data sharing within your nations, but then regionally and internationally. There is some sense of some pushback and trepidation from governments now with this increasing cybersecurity drive. I think it would be interesting, I don't think that would be another whole webinar, but you know, collective messaging about the importance of international data sharing in genomic healthcare, you know, even if it's regional, if that's more palatable. I think we all need to be really sort of advocating for the importance of this for, you know, the sector more broadly.
I fully agree, and we are part of the 1+Million Genome program in Europe, where we are sort of preparing for data sharing from our national genomics platform. But I think that will not be enough. I think we have to think internationally, especially for rare diseases and rare cancers. So we are preparing for this, and we, as a small nation, we have to be part of international collaboration. I think that is key, and the European health data space will help us, because then secondary use of healthcare data is possible in a totally different way than before.
And I would echo that. It's fundamental to be able to use the genomic data in an effective way. And as we generate more and more, it's becoming incredibly challenging to actually interpret it and put some clinical outcomes onto the data. So if we can learn from ourselves, as in events and outcomes from how we're classifying the data, then I think that will speed up the process, because we need to future-proof it, because we can't, that is where there's a huge workforce issue and a capacity issue, is about how you handle the data as it comes out. So we need not only sharing to generate advances, but sharing to actually be able to interpret what we're finding is going to be really critical.
Thank you. Maybe just to close off, final minute of the panel. Krista, we've talked a bit with the Sweden case about a bottom-up approach. I'm maybe keen for the audience to hear from you a little bit about how patient advocacy can sort of add weight to that bottom-up approach.
I've been in this space for over 20 years now. I've seen it all. I've seen promises that haven't been delivered. I've seen, leaders that have said things that will happen that never did. At the end of the day, it's the top down. Like, we need the funding, we need the belief. The Prime Minister, David Cameron, he had a son with a rare disease. He made this his mission and his legacy, and he put everything behind it. And what it takes is a small group of people who have power that come together and make a decision that this is important, this will change healthcare, and this is what patients need, and it will happen. And I think what happens in that situation, it's the bottom that comes together, that rises up. It's patients, it's clinicians, it's industry, it's everyone coming together that's saying, this is what we need. And you need to deliver it for your citizens, you need to deliver it for healthcare. And that's where advocacy comes in. You will not achieve it without advocates and patients and organizations and leaders. We are the ammunition that the healthcare sector needs to be able to achieve equality in genomic healthcare. I'm sick and tired of being one of the lucky ones, being given the gift of a genetic test at the right point in my life over 20 years ago that allowed me to change my family's history and change my future. I'm going to die at some point. I just wanted to elongate that for as long as I could. I didn't want to go in my 30s and 40s, and that's what happened in my family. So for me, genomic healthcare given to a patient at the right point in their life, whether it's for prevention, diagnosis, or treatment, can change the trajectory of their life. And it will take all of us to make that happen and bring that to fruition. It does not matter money. It does not matter data. If there is people that want to implement this, aka prime ministers, big health leaders, they will make it happen. They'll collect the data and they'll bring everyone together. And we just need to find those people.
Thank you so much. Great. Well,
just-
thank you.
I could just very briefly say that I fully agree with you, and I have been a doctor for outpatient clinic for inherited cancer for more than 20 years, and I fully share your view, and that is why we have patients on our board, on the national board, that are part of the whole genomic medicine in Sweden, and we have actually written a report on patient engagement, and we are very much trying to live after that, to engage them from the beginning to the end, because we think that is central. And I also agree with you that we should stop saying we should offer all patients, cancer patients, genomic testing. I think that must be our goal.
Yeah, and we'll get there if we all work together.
Absolutely. Great. Thank you so much to all the speakers and panelists. I'll just close with one final slide, finishing up on the same note, actually, about how we need to all work together to make this happen. So in the sort of call to action and conclusion of the paper, we really call for all of the healthcare ecosystem stakeholders to work together. So whether that's from the top politicians and policymakers, all the way around the whole sort of circle that we see here, from payers, providers, clinicians and pathologists, the industry, academics, and patient advocacy groups. So really critical message, I think, to come from this is, in order to reach this shared goal, we're going to need to collaborate. We're going to need to bring everyone together to achieve that. So with that, I believe we're a couple of minutes over time already, but thank you all so much for attending. Thank you so much to our panelists and speakers, and thanks also to the APACMed team and my Vista Health team. So thank you all very much, and wish you a good evening or day ahead.
Thank you, everyone.
Thank you.
Bye-bye.
Thank you. Bye-bye.
You want a photo, right? We're not to leave.
Yeah, we took some. Anirudh, let's spotlight you, and then let's take one final one. Yeah. Great. Yeah. Yangshan, Michaela, if you could just grab a quick one. And I guess everyone's smiling rather than talking, as we probably were in the other ones. Yeah. Okay. Taken.
Good.
Of you. Thank you.
Great.
Thank
All
you,
right.
everyone.
Thank you all so much.
Thank you,
We'll be in
everybody.
touch to
And
follow up
Richard, I
afterwards.
love your work. Please continue
Yeah.
it. On behalf
Yeah.
of patients and advocates, don't stop. And please share it with us so that we can use your knowledge and
Yes.
use everything that we can so that we can make the rest of the world better.
I fully
Thank
agree.
you.
So much.
Well,
Thank
thank
you.
you.
Thank you, everyone.
Thank you. Bye.
Bye.